Thank you. Really good to be with you and all of you virtually today. And it's wonderful that I think all of our presentations are really going to be resonating together, because I think there's a broad awareness of the need for charting this course for an equity-centered data system, really the primacy of that being community-centered and community-driven. And that's certainly the framing that I'm going to share with you today in my 10 minutes, which is really going over some of the recommendations of the National Commission to Transform Public Health Data that we launched and took part in last year. And everything that I will say is in that report on our website, as well as a lot of other ancillary documents and research that went into this. So I would refer you to that for more. Second slide. We're your partners that work with us and have worked with us for many years, and I can see from looking at the materials, many of you in this meeting are innovators at what this needs to look like at a community level. And I would just say with this slide that we are really rooted in this work in partnership with others. And this has been really, we think data equity and equity in general is a driving and operating force for what we mean by building a culture of health. Next slide, please. As I said, we've been working with all of you around these issues for a long time, and the work that I'll talk about over the last year and continuing this year on transforming public health data systems really built on and continues that work. And so we've been invested in that for a long time, and really trying to understand the role of data and equity, data as a driver of necessary policy change at the state, county, city, census tract level. And again, the great work that I think will be discussed by many of you who have been modeling this on the ground for years is an important part of the discussions happening today. Next slide, please. As our CEO, my boss, Rich Besser, said, if we're to become a nation that truly values health equity, public health data must reflect fairness, justice, inclusion as a fundamental requirement. Again, data are more than just information. Data are the way that meaning is constructed. They are the elements of discourse and narrative that really creates a broad story of what is actionable, what is not actionable, who is included and who is not included. And I think coming out of the last couple of years with COVID, with the delayed racial reckoning from the George Floyd murder, something about addressing this particular pandemic and the endemic of racism points out very explicitly both, again, the imperative of a data system that is more real-time and far more community-based and engaged. Next slide, please. So our commission, we established this last year based on a lot of research that we did prior to the commission, and you can see this all on the website, around trying to get to everyone who is working on these issues to get those perspectives and insights led by Rand. The commission was led by Dr. Gail Christopher from the National Collaborative for Health Equity, 16 members representing many different sectors. Karen DeSalvo is one of those commissioners, and they were charged with really trying to reimagine how data are collected, both on the public and the private side. And I think as we operationalize this in our work at the Foundation and the Commission, public health data system means more than just the governmental public health system. It means the publicly needed data to understand population health, particularly as it is optimally driven by a more community-centered and community-partnered approach to the construction of data. Next slide, please. So the commission report really centers the work on health equity. And I know we have a tendency to shortchange this in data modernization, but the downside of that would be modernizing existing data, the more efficient interconnectivity of existing data, when we really do need a radical reconceptualization of even those data elements as well as their connectivity to address issues, structural factors like racism and other factors that marginalize people that become really clear in a pandemic, but our monitoring system should make those inequities clear even when they do not reach the proportion of a pandemic and a kind of a recognized disaster versus a chronic disaster. So data centering on equity is what this commission looked at. Next slide, please. So this quick summary of the recommendations, 3 major areas. Center health equity and well-being in the narrative change. That's kind of a where we fall behind, I guess, the rest of the world, particularly other nations like ours, is the lack of positive health data in our data systems. Prioritizing equitable governance and community engagement, as was just mentioned. Trust is built through collaboration, data that just emerges in crisis that hasn't had that genesis in trust building, community-centered processes are going to be doomed to have limited impact. And then the third, ensure public health measurement captures and addresses structural racism. Our data system, which measure disparities, are not metrics that measure how you will resolve the problem, how you will close the gaps. And may not be measuring in a sufficiently nuanced ways the kinds of social determinants that you need to look at if you're going to monitor and improve and mitigate the effect of structural racism on health. Next slide, please. So quickly, overarching recommendation number 1, centering health equity and well-being in narrative change. Data are the building blocks of population health narratives, the stories that we tell. Sometimes we tell them as scientists, sometimes they are told in the media, sometimes they permeate and they're told in communities. But if we have the wrong data, we are not going to have the right stories. And if they are not collected and informed by community experience, and if they are not addressed in the sufficient hyperlocal way, they are not going to be actionable at the level that they need to be to resolve health inequities. So the commission spent a lot of time on trying to say that a modern equity-oriented data system really needs to be more inclusive. I think I'm preaching to the choir on this one, but it is really that it's challenging sort of the default nature that these data systems are the province of large organizations and then shared with people sort of as an after fact. Next slide, please. Overarching recommendation number 2, again, the importance of governance. It was stated earlier. Those of us who've been in public health practice, Boston, Seattle, LA for me, we used to say in response to any disaster, if you're just beginning to connect with people in the emergency response center, you've lost it already in terms of your response. If you're beginning to share data and engage with community in the midst of a crisis, you're way behind in terms of the kind of trust that's going to allow an effective and engaged response. So these governance systems, all of what we're learning, and again, many people in the virtual room are the pioneers and experts in how to do that. We really need to begin to actualize and really spread the learnings about how you develop these governance and community engagement systems that work. There's not a one-size-fits-all for this. These are very regionally and locally nuanced, but again, right, we have to address the inconsistency of those kind of governance practices across data systems in the country right now. Next slide, please. Overarching recommendation number 3, ensure public health measurement captures and addresses structural racism and other inequities. If structural racism is a public health problem, as the CDC director said, we do not have a public health data system that is up to the task of understanding, measuring, capturing, and addressing those inequities. It is not just the interconnectedness of existing data. It is a lot of different kind of data. I would just point out one, this total absence, again, compared to other nations, of positive health well-being metrics. So we are working in partnership with CDC now to begin to offer some ways to do that, particularly within the behavioral risk factor surveillance systems and other ways. But to be prepared for the next pandemic, or to be prepared for the ongoing issues that we need to deal with community health improvement, got to collect data in an equitable way and actually understand what it means to the proper measures to understand the indicators for action. Next slide, please. So the report ends, as good report should, with a call to action, which are many of the things you're going to talk about more for the rest of the day. Connecting, again, public health data, this means all health data, to local communities and having those communities involved in the generation of that. Local voice represented in data construct, not just data utilization. Exploring data collaborations. And again, the virtual room is filled with folks who've been working on developing those. We just need to norm those and make them much more prevalent in our communities. It's all about multi-sectoral collaboration. As everybody on this call knows, the social determinants data are really not in the public health data system or the health data system. And then modernization is way more than tweaking and refining our infectious disease control surveillance systems, which would be the default and tragic implications if we just took that lesson from COVID. Next slide, please. So we have short-term recommendations. We're working with CDC and others around this governance structure and reconstruction data, the governance issues, and we can learn a lot from those of you who've been working on the ground on this one about how to do this, the advisory councils that you develop, the co-creation of data that I think are part of what you'll talk about later in the panel. Power sharing is absolutely essential, that was just said earlier, building community power through actionable data to policy change is probably the major thing we can do with transform data. And I think all of that will develop different messaging and address some of the trust issues. Longer term, workforce, not just in the healthcare sector side, but in terms of community capacity to use information in an actionable way, community commons models. How do we begin to share in a dynamic way data development, action-oriented data, sustained community engagement, support to particularly state and local public health to do that community work, and again, with an equity, racial justice framework. Next slide, please. In with this one, out of the commission, we've done an initial awarding of about $50 million in funding to really try to model and be a catalyst in what this might look like nationally. The Transform Local Data Environments, this will be launched through our partner and intermediary, de Beaumont, 4 places around the country, in partnership with state, local public health, CDC, many other organizations. What does this look like from the ground up, and how can we model this? Building community academic partners. This is another variation of that, linking some really good work that some HBCU faculty have been doing on creating equitable, climate justice informed public health databases in the Gulf South. We're doing that with another part of the Academy, the Gulf Research Program. And again, more meaningful data disaggregation going far, far beyond where we are now with the current ways that we deal with racial and other even disability disaggregation. Final slide. So thanks. I would love to be with you for the entirety of this, but it bumps up against my board meeting that actually starts at 1:30. That's where all of us are going to be in a minute. But I look forward to learning about what the findings and things that are going to be discussed in the meeting. I know many of you in the work that you're doing. I think we all recognize the urgency of the moment, and we look forward to working with all of you as creating the kind of transformational change and energy that the nation's health data system requires.